Thank you for the invitation to join the symposium today. I'm clicking on the next button. Maybe you can help me advance, actually. Okay, there we go. These are my financial disclosures. This is just a brief outline. We'll look at some real-life data. How often do we perform surgery in our clinic practice? And then the three topics that I was asked to speak on were amniotic membrane transplant, lid surgeries, and conjunctival grafts. So we had a great introduction this morning. So how often are surgical remedies required in neurotrophic keratitis? We looked at 37 consecutive eyes over a 6-year period that came to the clinic, and we found that about 2/3 more of them even required some form of surgical intervention. Most of the cases, over 50%, were cases that had a history of herpes simplex virus or shingles that caused the neurotrophic disease. So looking into details of what was done, over 50% underwent tarsorrhaphy, 3 eyes, 12% had amniotic membrane grafts, and 1 underwent a Gunderson flap, with a few undergoing keratoplasty for tectonic purposes or optical. So when would we use surgical interventions? Looking at staging, we can group it by stage 1, where there's just early superficial punctate keratitis changes, moving on to epithelial defects in stage 2, and stromal alteration and thinning occurring in stage 3. This is a nice graphic from the paper quoted that end-stage dry eye disease, we get neurotrophic corneas, and this explains why in dry eye, the signs and symptoms really don't correlate well. In neurotrophic keratitis, you end up getting severe dry eye disease because patients are not blinking and they lose their reflex tearing. So there's this vicious cycle and overlay between the two. Not sure if there's a bit of an echo. If everyone's on mute, it might help the guests here to talk a little bit better. Okay, so you can see the next slide here. We're talking about epidemiology a little bit. This was a great study looking at over 8 years of experience, over 300,000 patients, with 335 patients presenting with neurotrophic keratitis for a frequency of 11%. Interesting, they showed that there were about equal distribution of patients in stage 1, stage 2, and stage 3. And it's possible that we're actually even missing some more of the ones who are in stage 1 because we're actually not testing, or we're just assuming that these patients are dry eye disease patients and not checking their nerve sensation. Herpes simplex virus was the most common in about 1/3 of the patients. And what's interesting here was that amniotic membrane was used for stage 2 with a success rate 57.2%, healing on average 16 days. Stage 3 was able to heal on average 16 days as well, with a success rate of over 60% there. Things that were associated with worse outcomes and worse final corrected distance vision included advanced age of the patient, advanced neurotrophic keratitis stage, as well as decreased vision to start with. So this leads us into our amniotic membrane section. What is it? It's the innermost layer of the fetal membrane derived from fetal tissue, and it's adjacent to the amniotic fluid sac. So why would we use this? We know that it promotes ocular surface healing by suppressing inflammation, scarring, fibrosis, and neovascularization of the cornea. And it's actually made very similar to the corneal structure, with a single layer of cuboidal epithelial cells, a basement membrane, and then the avascular stroma. So this is a case of a 30-year-old man who, after cross-linking, 4 weeks later still had this persistent epithelial defect, very central in the area of the cone. And he was essentially neurotrophic from years of rigid gas-permeable contact lens wear, as well as from the cross-linking itself, which has demonstrated a neurotrophic effect. In Toronto, I'm most used to using fresh frozen amnion that's prepared by the eye bank. And the 9-0 Vicryl suture is really excellent for suturing a nice purse string securing suture, and that keeps the amnion from moving. The fresh frozen is a bit thicker and heavier, so I found that just glue alone doesn't hold it as sturdily. And I apologize for some of the formatting issues as the talk was transitioned onto this platform. It looks a little bit different. So this is a video of, you can play the video here, of how that surgery is performed. Perhaps I could ask our AV assistants to hit play on it. I'm just seeing a circling line and not sure that the video is showing.
Can the audio visual please help?
Sorry for this.
Dr. Chen, do you want to move on to the next slide? We can
Sure.
always come back to this.
Yeah, we can resume the videos later. So the next slide here, we'll look at just some surgical pearls. It's important to debride the uneven necrotic edges of the epithelial defect because that will impede the growth of the epithelial cells over the amniotic membrane, basement membrane. You want to avoid tooth forceps, which will maybe puncture through and create buttonholes. In terms of tissue orientation, the sticky side you can always test using a wet cell, and if it sticks on the surface, then you know that's the stromal side. And sticky side, if you put that stromal side down, then the epithelium sometimes integrates into the cornea stroma, creating a bit of opacity scarring appearance. So it does last longer, but visually sometimes that might, if it's central, it might impede the best corrected vision later. Typically, basement membrane down is nice. It acts as a patch graft and the epithelium grows underneath, and it also dissolves a bit faster to return the patient to vision. Here, maybe we can, sorry, this is just showing the different ProCara devices which have been touched on. I did want to highlight there is one that has a central opening to it so that patients can still see through it, but it is bulkier. It does come in a less bulky form, but that just shows the different configurations. So this is just the, this is a dehydrated amnion, which I have experience with in Toronto. BioD is the nickname. It comes in horizontal, square, rectangle pieces, or in the disc form. So in the disc form, I typically use the 9mm one, and I do have a video showing the application of it, very similar to the earlier AmnioDisc video that was shown. Not sure if this video is going to work or not. But what we could do is just, I'll just move on, and then any of the videos, if anyone wants, we can always send them out later, or we can show it at the end of my talk. So these are the initial cases that we used. There was a 41-year-old man with herpes simplex virus, post-keratolimbo allograft stem cell transplant, had a massive herpes simplex flare-up, and suffered from a persistent epithelial defect. So we used the BioD disc on him, and that helped to settle the defect. I usually see them back about a week or two later, and by then the disc has dissolved, and we can remove the soft lens. The next patient was a 62-year-old man with Stevens-Johnson syndrome, having had a Cincinnati procedure, which is a combined keratolimbo allograft with living-related stem cell transplant. He then had a subsequent penetrating keratoplasty. Also, post-op had a extreme herpes simplex virus flare-up, persistent epithelial defect, and with the disc, it helped just get him over the hill to heal up. Another 43-year-old female with Stevens-Johnson syndrome, very photophobic, very dry eye, persistent epithelial defect. With the disc, it allowed her to resolve her significant photophobia, which she was relieved about. 65-year-old female who had a history of herpes simplex virus after penetrating keratoplasty, also had difficulty healing, and it was helpful there in her case. 52-year-old female with Stevens-Johnson syndrome also had a Cincinnati procedure, developed fungal keratitis, Candida parapsilosis. We treated that with corneal cross-linking, but she had difficulty healing a small area. We didn't want to keep the eye so inflamed and stress her stem cells, so we used the disc, and that assisted with her healing. So this is the other form of dehydrated amnion. It was discussed earlier briefly. You can get the disc form as well as rectangular pieces among different sizes. The key with these ones are you want a very dry surface. Otherwise, when you put it on, it doesn't stick well, and then it starts moving around. And you want to put the lens on and then be careful when you remove the lid speculum that you don't dislodge the lens or the dehydrated piece that you've placed. In terms of tarsorrhaphy, there's 77 patients over 5 years was shown in this study. The majority were permanent tarsorrhaphies done. And after tarsorrhaphy, over 90% of these eyes healed the persistent epidefect. The average duration of signs and symptoms prior to tarsorrhaphy was quite long before tarsorrhaphy was done. We do find this in clinical practice as well, as patients are very hesitant when you explain this procedure to them that they're going to look, cosmetically abnormal and be fairly deformed with one eye closed or partially closed. So patients don't like this option very much. Time to healing was similar to amniotic membrane, about 18 days plus or minus. In terms of complications, certainly you want to be able to make sure lashes don't poke inwards, you don't get keratitis. The adhesions you can get sometimes, like kind of webbing, it looks like, as the eyelid's stretching out. Any sort of, if you don't get a good closure or tight closure with the initial sutures, the tarsorrhaphy can open up. You can get pyogenic granulomas forming, especially in patients who are darker pigmented, or keloids. So those are things just to touch on with the patient as a potential risk. But it is very low cost to do a tarsorrhaphy, probably the cheapest intervention of all the things that we have available to us to treat NK. We use it for exposure keratitis to decrease the dryness and reduce exposure, persistent epithelial defects as described, and then very importantly, as prophylaxis in corneal surgery. So at the time of any transplant, we always lay down extra amniotic membrane, and then we do a tarsorrhaphy so that even when the amnion dissolves, the tarsorrhaphy is still there to help ensure healing of the surface. Similarly, at the time of a limbal stem cell transplant, just to protect the surface, improve wetting, and then reduce exposure, protect those stem cells to try to get them to heal quicker as well. And then at the time of a Boston keratoprosthesis in eyes that are known to be very dry or are at risk for not having a contact lens stay on. So as mentioned, there's a permanent kind. You have to ensure you debride the lid margin. Also, for temporary, you can either use sutures with bolsters, or pharmacologically, we can use Botox as well. So Botox, some tips for using Botox. You want to use a 30-gauge short half-inch needle. Approximately 12.5 to 15 units of Botox are used. The first step is to inject along the center of the superior orbital rim and aim a bit superiorly so you're not going to hit the globe. And then for the second injection, you want to go into the upper part of the central eyelid. One way to be safer is if you want to evert the upper eyelid and then inject directly straight ahead, and that way you'll have much less risk of hitting the globe, and you're getting right at the needle as well as the ligator. There is a small risk of losing the Bell's reflex due to superior rectus underaction, as it also receives a bit of the Botox as well. And approximately lasting about 5 to 6 weeks. So these patients do need to come in regularly to get re-injected, and there's also a cost to the Botox as well. So this is a case of a 74-year-old lady with a sterile ulcer from shingles. There was supposed to be a video here showing the steps of doing the surgery. And essentially one of the tips I wanted to show was how we do a double bolster. So I'm assuming this video is unlikely to work either. So I'll just move on here. So essentially this is just showing how the double bolster helps to secure the upper eyelid and keeps it closed because gives it a bit more friction. So you can easily open it up in order to examine the eye, and the long end of the suture just gets taped to the patient's forehead until their next visit. I wanted to show a very quick and easy tarsal temporary tarsorrhaphy, which can be done at the bedside. And here you don't need any bolsters. We're actually using the patient's actual tarsus themselves as the anchoring component. So by putting the suture, you can see it's like a mattress suture, essentially through gray lines, through tarsus, out the lateral side, and using a double armed nylon suture, 5/0 or 6/0. Do the same with the top, and as you cinch it down, the eyelid beautifully closes, and it's probably one of the most efficient ways to do it. And this stays actually for months and months. Like the tension strength in the 5/0 or 6/0 nylon is really good. Oh, a video works. Great. So here we go. We can show how that's passed through the bottom lid there, and also through the upper lid. And just very simply, it's just you want to make sure that the suture is extra tight and that latches aren't stuck in between. But this is a nice resident, level suture procedure that they can do for ICU patients or post-op patients, anyone who needs it. In terms of conjunctival flaps, this is just a review looking at Gunderson, which is sort of the classic total conj flap that's done versus partial conj flaps. Once again, the majority of patients had singles or herpes virus, and complications in these cases are often due to flap retraction. Two of them in there was two cases that needed resuturing in the total conj flap, and then in the partial flap group, one case needed the flap retracted twice, and eventually that patient needed tarsorrhaphy. And then in one patient, they developed a perforation after retraction, which needed penetrating keratoplasty. So this was supposed to show a video of the Gunderson flap, but some tips on doing that. You really want to make sure all the corneal epithelium is removed, and the conjunctival flap should be very mobile and very thin. You don't want any tenons there because the tenons is what causes the retraction and contraction. You want to avoid any buttonholes, but it's not the end of the world if there is a buttonhole, because you can use some tissue glue underneath and then that just opposes it. But the goal is that there's really no traction. Just briefly with the steps, you would do a 360 conj peritomy, and then also superiorly about maybe 11-12 millimeters back superiorly, you would cut just make a horizontal cut so that that's where that would become your new superior part of the libus, and the conj graft just slides right down. So this is a case where a patient presented with a childhood herpes simplex scar and had developed a perforation. The eye was amblyopic, and we needed to do a small lamellar keratoplasty with a partial conj flap. I'm not sure if the video is going to show. In any case, we'll move on to buccal mucosal grafts. So this is a nice technique for any patient who you need sort of a conjunctival mucous membrane material. So we've used it in tube erosions for K-Pro melts, and then in patients who need a Gunderson, but their conj is just all scarred down, or they've had previous tubes, previous trabs. You don't want to cut into those areas and have a gaping hole exposed. So you can harvest from the inner part of the mouth. And perhaps the AV people, you could try just clicking on the play, because at least that might give us the chance to play this video. In any case, we're using a Castro Viejo Trefine, and just you roll it, as you would on the cornea, but it's on the inner side of the lip after freezing it with some lidocaine with epinephrine to control bleeding. And then you can just dissect that off and cut off all the extra fat that might be stuck. The lip is just closed with a gut suture, and that dissolves really well. The patient just feels a bit of numbness, but it feels like they just bit their lip. There's very little pain from the actual mucosal graft harvesting site. And then when you place it on the eye, you can just suture it with Vicryl sutures. And then the first day when you see them, it's completely avascular. It's usually kind of fleshy beige looking. And then by week 1, the blood vessels typically grow in quite quickly, and you get sort of this very thickened red vascularized piece of tissue appearance. and then it thins out over time, over the course of a month or two, and then it eventually thins out to the point to look like natural conjunctiva. Oh, it works. So great. You can see we're just marking and doing the injection here. And so that's the trephine used, the original Castro-Viejo one. So you want to try to minimize the amount of fat that you actually excise. Or sorry, cut away all the fat to minimize the fat that's left is what I should say. So then cautery, just regular sewing up the lower lid there. And somehow all these patients have the best dental hygiene too. I'm not sure why. You can see the nice yellowing effect. So you don't want to have any areas that are gaping open where fat can come out. So in summary, surgical treatments are needed in usually stage 2 and 3 neurotrophic keratitis to avoid melting perforation. You still have to aggressively treat the dry eye component. Amniotic membrane transplant is best used prior to seeing any stromal scarring. You can quote to a patient it's approximately 60% success, and if unsuccessful, tarsorrhaphy also works well, over 90% success. And I typically do both amnion and tarsorrhaphy at the time of any tectonic graft. Also consider conj flaps, which have a low complication rate as long as you avoid retraction. And just keep in the back of your mind that buccal mucosal grafts can also be a useful adjunct in your armamentarium. I want to thank the team in Toronto. We have our cornea fellows and all my colleagues that have a nice supportive environment for us to work. Thank you.